The first question, can everyone see this? So, what is the name of this catheter? What is the balloon filled with? And third question is, can you use it to measure wedge pressure? And what are its uses? What is this catheter used for? Okay, so this is a Berman catheter. By the way, should B be in small b or should it be in large capital B? Should it be small b or large capital B, and why the difference? So it's Berman because it's the name of the person who invented it, so that's why B is capital. So this is the Berman catheter. What is the balloon filled with? It ideally should be filled with carbon dioxide, but as you all know, in many centers in India there's no carbon dioxide in the cath lab, so we fill it with air, which is not ideal. So if someone asks you what it should be filled with, just say carbon dioxide. For practical purposes, centers here use air, but the problem with air is if the balloon ruptures, you will actually have air embolism, unlike carbon dioxide, which will then just dissolve in the bloodstream. Now, can you use this to measure wedge pressure? It's not used for wedge pressure, but can you use it? Can you get wedge pressure with this? And everybody understands no, right? Everybody understands why not? Because it's got, as you can see here, multiple side holes. And in order to measure wedge pressure, you need the end hole. And I just want to actually spend a minute to go over this for the new fellows. When you have to measure a wedge pressure, you have an end hole catheter, right? Okay. This end hole goes into the pulmonary artery, right? And then you have a balloon here. So what is the end hole then measuring? It is measuring the distal pressure because the balloon is preventing the pulmonary artery pressure from getting transmitted. So when you put it inside the distal part of the pulmonary artery, inflate your balloon here with a Swan catheter, then this is measuring the part of the pressure distal to it, which is the pulmonary capillaries and essentially pulmonary capillaries. So it's a reflection of pulmonary veins, and if there's no pulmonary vein stenosis, it's a reflection of left atrial pressures. Okay, so when you have multiple side holes, you cannot wedge it like that. It doesn't have an end hole, so it's not used for wedge pressure. What are the uses of this catheter? In which conditions are you going to use this catheter? Which? So PDA balloon occlusion. Okay. Now before you say PDA balloon occlusion and angiography, which angiography is it especially used for? It's an angiography catheter because it's got multiple side holes. It's a balloon tip, so it's actually a very safe angiography catheter. So it can be used in the right ventricle. That's right. Now in the right ventricle, the big advantage of a Berman catheter is that it's got this balloon. So you don't get anything that is stuck inside the trabeculae of the right ventricle. So it's very good for right ventricular angiography as well as RV pressure, and for measurement of pulmonary artery pressure. You can use it for injection in the pulmonary artery. Some people use it even in the through LA into LV, which is fine. So basically angiography. Now if you want to use it for PDA balloon occlusion, you're basically going to put it from the pulmonary artery side, occlude the duct, and the proximal parts are going to measure the PA pressure, which is okay. It's not good if it's very large ducts. Why? Because how much does this balloon inflate to? What size does it inflate to? Let's say you blow up the balloon maximum. Typically, what is it going to get to? Around half centimeter, 1 centimeter, okay, 0.75 or 1 cc. So that is, it's not, you're not going to get it very large, maximum a centimeter, and typically less than that. So a 6-7 mm duct you could, but if you have like a 12 mm duct, 14 mm duct, you can't use a Berman, then you have to use another catheter. Okay, so all clear on the Berman catheter. We'll move on to the next catheter. What is the name of this? Oops, how did the answers come up? 1 second. Not supposed to have the answers right away. Let me see. Anyway, there they are. So what this catheter is a reverse Berman. You can see here that there are holes which are distal to the balloon, right? Multiple side holes distal. Now, can it be used for wedge? Again, the answer is no. The reason being you don't have one single end hole, you've got multiple holes. Now, where this is very useful, if you remember last week we discussed the peripheral pulmonic stenosis and geography of that. just imagine if you have a distal branch that's narrow here, right? So you want to look at this, but every time you inject contrast, it's running proximally through because of pulmonary regurgitation or because the path of least resistance is the RV. So you're not filling that pulmonary stenosis very well. Reverse Berman, if you can get it in position, is good because you inflate the balloon here. All the dye will have to go distally. So you show the pulmonary arteries very well. So in fact, this can be used, you can put it in your main pulmonary artery. Say you have a patient with pulmonary regurgitation, like a post-op tetralogy. You put this in your main pulmonary artery, inflate the Berman, so the balloon. So it blocks the blood from coming back into the RV and all the blood goes into the pulmonary artery. So very good for pulmonary angiography and also used to see the coronaries in DTGA. If you go from the aorta, put it here, inflate the balloon, all the contrast is just going to go into the coronary artery. So two uses of reverse Berman, pulmonary angiography and coronaries in DTGA. Now it can also be used for pulmonary vein injection. If you go from the LA into the pulmonary vein, then you occlude the entrance of the pulmonary vein. The blood doesn't come back into LA and inject and it goes into the pulmonary circuit. So in times like pulmonary atresia, when you want to, many times we take a right coronary, we do a reverse pulmonary venous wedge injection and we go into the pulmonary vein and inject, but if you see a lot of that dye comes back into the LA because obviously the blood will go down the path of least resistance and so the contrast will also come down the path of least resistance. So in a pulmonary vein, the other thing to consider is this. Problem is you have to be careful when you inflate the balloon because you don't want the balloon inflated inside the pulmonary vein because those are thin structures and you can cause pulmonary vein rupture. So if you're doing this, it has to be, you have to be sure that you're in the LA part when you inflate the balloon or inflate it very gently, don't fully inflate it. So it has to be done with care. Okay, all clear on this? Now an ECG for you guys. I hope everyone's had their coffee. So what I've actually marked out, you can see the portion. So what do you think this is? Hi Sudeep, welcome. We have a new E-classer today. So what do you all think this is? Coffee? So you think it's MAT. Everyone knows what's MAT? So Mridul says multifocal atrial tachycardia. Okay, and that's right. Can you all look at these P waves here? Now the first thing you see is that this ECG, the QRS complex is irregular. Okay, you don't have a pattern of your QRS to QRS. Right? There's QRS. You look at the look. I just look at the path that I've circled. The first two QRSs are close, then it's further off. Second is it's narrow complex. Right? The rate is varying between 100. In this case, it's somewhere about 100 to 150, that range. So whenever you get a narrow complex, but irregular ventricular rate, not a very fast heart rate, 100, 200 rate. It's not like an SVT which is 200, 250 rate. And you have to then look carefully at your P waves, right? Now, if you look at your P waves, the first two P waves are, there's one like this, then there's one little peaked, then there's one that's inverted, right? So there are varying morphologies of your P wave, and that is your clue that this is multifocal atrial tachycardia. Now the P wave before the QRS should have different shapes. How many different shapes? At least 2, 3 or 4 different P wave morphologies. All agree? That's right. 3 different P wave morphologies. So if you look at this, you've got one that's like this, and that different P wave morphology doesn't only mean upright and inverted. It can be that if voltage is less, voltage is more, inverted less, inverted more. It can be any different variation of P wave morphology. So if you see in this thing that's encircled, look at the first P. It's kind of very shallow. Look at the second P. It's a little peaked. Look at the third P. It's inverted. So when you see 3 different P waves before QRS complexes with a QRS ventricular rate that is irregular, this is multifocal atrial tachycardia. Now look at your V5, look at the lead V5 in this. You could actually, if you look at the bottom lead, you could get confused and think, see, as we discussed last time, it's irregularly irregular, right? You could say, hey, irregularly irregular, this is AFib. But then when you look at your other leads, you're actually seeing P waves. You're not just seeing a fibrillatory baseline. And then when you look carefully, look at lead 2 at the bottom there. You have inverted, little less inverted, little upright, little something different. Then that's your clue for multifocal atrial tachycardia. Okay, all clear? We'll move on to an echo image. This is just a short, you're going to see just 2 images. This is a sort of modified short axis view. So anyone for the see if you can come up with the diagnosis. And next is a long axis view up here. Okay, so you say that there's a left main coronary artery dilated, right? Now what runs? Now look at this long axis view. So what could that be? If you see the left main is dilated. Okay, could be Kawasaki. If you see a coronary that's dilated. Normal, what is so say I tell you that this is a 4-year-old child. What is the normal size of the coronary arteries in a 4-year-old? Normal size of coronary, 4 millimeters, that's right. So this is definitely dilated, could be. Now what runs in what is the other thing you think of when you see a dilated coronary artery? So one, you think of Kawasaki, but okay, this patient has no history of Kawasaki. What is the other thing you think of when you see a coronary dilated? You think of a coronary cameral fistula, or what is called as a coronary AV fistula. Now which coronary artery runs in the left AV groove? So not LAD, not LAD, in the left AV groove. So where does the LAD run? So the left main comes out. LAD runs in what? LAD runs very anteriorly, and where does the LAD run? It runs in the interventricular septum, right? In the interventricular groove. The left circumflex runs in the left AV groove. So if you see here, this thing is trying to go towards your left AV groove and then open up. So this would be a circumflex, from the circumflex moving into the RA. That would be, and you can see here in the short axis, it's opening up into the right atrium. So this would be a coronary cameral fistula via the circumflex. Now if you look here in this short axis view, you will actually see, look up here, your LAD is normal beyond. So you know that it's not involving the whole left coronary artery. Okay? Everyone read, and where is the right, ooh la la, how my answers are coming up. Where does the right coronary artery run? So it's left anterior descending runs in the anterior interventricular groove. Left circ runs in the left-sided AV groove. Where does the right coronary artery run? Oh, coffee this morning. Everyone's going to read coronary anatomy again. Where's the right coronary artery run? Which part of the heart? That's right, in the right AV groove, right? So it runs in the right AV groove, left circumflex, left AV groove, and LAD in the anterior interventricular septum. Okay, now what are the common sites of drainage of AV fistulae? Which is the most common? Right heart, left heart? First question. Right heart or left heart? Right heart. So all agree in the right heart. Then in the right heart, in which part? And this you will see that different textbooks give you different ones. But what is your commonly accepted? Which is the most common? Into which part? Into the RV. Right? So these are the common sites. Right side of the heart, 90%. And then LV, LA, coronary sinus. In the right side of the heart, first right ventricle, then right atrium, then pulmonary artery. Okay, so everyone just This is your classic exam question: right ventricle, right atrium, pulmonary artery. Okay. Now, what are the modes of presentation of coronary AV fistulae? How are the different ways in which they can present? So one is they could be asymptomatic, but they would have a murmur, right? So where would the murmur be? If it entered into the right-sided part of the heart, what kind of murmur would it be? If it enters into RV, RA, or PA, it would be a continuous murmur. That's right. Continuous murmur heard very superficially. How would the murmur be if it entered into the left ventricle? So diastolic, right? So because aortic pressure says 100, LV pressure is 100 in systole. You'll have no flow in systole. In diastole, aortic pressure is, let's say, 60, LV diastolic pressure is 5. So you have a diastolic gradient. So if it enters in the LV, you'll have only a diastolic murmur. What other lesion has a diastolic murmur? Common lesion is AR, right? So that's why a coronary cameral fistula to the LV will present similar to aortic regurgitation. Now, if it goes into the LA, if it goes into the left atrium, what will the murmur be? It's again going to be continuous. So the only place you have a diastolic murmur is when it's into LV. Into all other locations, it is continuous. Okay, so the first presentation of AV fistulae, it can be asymptomatic. What are the symptomatic presentations of coronary AV fistulae? Recurrent RTI. Okay, why recurrent RTI? Because of heart failure. Okay, so it can present, if it goes into the right side, it can present as a left to right shunt with congestive heart failure, all the symptoms of CCF, including failure to thrive, recurrent respiratory infection. Next, what do you say? Not rarely. Why do you say rarely coronary steel? See, the coronary steel is a very, among symptoms of coronary AV fistulae, coronary steel is the most important one. Heart failure is actually very rare. So if you're going to say rarely heart failure. Because if you think of all the coronary cameral fistulae you have seen, most of them are narrow where they enter into the RA or where they enter into the PA. So most of them actually don't present with heart failure. It's quite rare to have a coronary cameral fistula present with heart failure. It's more common for it to present with coronary steel. Now, why is that the case? Because your aortic pressure, let us say, is 100 by 60. That aortic pressure normally pushes blood down into the coronary arteries, which is perfusing the myocardium. When the coronary artery is connected to, let us say, a right ventricle, where the diastolic pressure is hardly 5 and the systolic pressure is hardly 25, what happens? You get a continuous murmur. What is happening because of that continuous murmur? In systole, it is not just a diastolic runoff. In systole as well as in diastole, there is blood running off from the coronary into the RV. What happens in normal coronary perfusion? It is only in diastole that you are able to perfuse the coronaries, right? In this case, in systole as well as in diastole, that poor blood is going from the coronary and pushing off into the right ventricle. So in systole, the blood has gone into RV. When you get to diastole, that is still going into RV. There is really no blood left for that myocardium. So coronary steel is a big and important method of presentation of coronary AV fistula. In fact, they can present with angina. If they are small infants, same things like your alpha, crying after feed, fussy after exercise. And as a result, the other modes of presentation are arrhythmias and sudden cardiac death. That's right. So why do they get sudden cardiac death? Because of ischemia. Now, this last week they had a case at Narayana where they saw a kid with a coronary cameral fistula at 4 days, had come back at 2 months for operation, and he came back in an arrested situation. So what had happened? He had coronary steel. So I think when someone asks you mode of presentation, first thing to say is asymptomatic if it's small. Next thing to say, if it's large, you can have myocardial ischemia and angina and heart failure. Now, I want to mention this heart failure. If you have heart failure with a coronary AV fistulae, it is going to have a wide pulse pressure. And this is one more of your examples of wide pulse pressure heart failure. What are your other examples of heart failure with a bounding pulse? What are your classic examples? Heart failure, bounding pulse. What do you think of? You think of PDA, you think of aortic regurgitation, right? You think of AP window. What else? So PDA, AP window, aortic regurgitation, truncus with regurgitation, LV to aorta tunnels, hemicruncus in the early stage, that's right. Vein of Galen, you start thinking of AV malformations, right? Then you're thinking of liver, hepatic AV malformations. Why not coronary AV malformations? So coronary AV fistulae can also present as heart failure with a wide pulse pressure. So keep that in your differential diagnosis. Now, long term, if untreated with a coronary AV fistulae, you get arrhythmias, you can get sudden death. Remember, you can get endocarditis. There's no reason you can't. You can get aneurysm formation. That part can become so huge, and you've all seen that hugely dilated coronaries that they can actually rupture. So when you're asked for modes of presentation, you need to start with asymptomatic all the way to sudden death, including aneurysm, rupture, endocarditis, arrhythmias, and so on. Okay. Now it's interesting if you think about it. When you have a coronary AV fistulae, right, that goes into the our right atrium, then it's a left to right shunt, right? So its presentation is similar to ASD, except that you have a continuous murmur. When it goes into the PA, its presentation is similar to a PDA. In all respects, clinically, you will think it's a PDA. And many times these cases have been thought to be PDAs. And when they go in, they find it's a coronary AV fistulae. So when you're thinking it's a PDA, always keep this differential in the back of your mind. Now, if the coronary AV fistulae goes into the left atrium, right, it's going from aorta to LA. So it is acting. It's not a left to right shunt, it's a left to left shunt. So it is acting like mitral regurgitation. You'll get LA volume load. Similarly, if it's going to the LV, as we said, you'll have a diastolic murmur and it will have a physiology which is similar to aortic insufficiency. So in all the differential diagnoses of these, when you have right heart dilation, one differential is coronary AV fistulae. When you have PDA diagnosis, one differential is coronary AV fistulae. When you have a dilated LA, you don't have a cause, this is another differential. You have a diastolic murmur, you think of AR, but it may not be AR, it could also be a coronary cameral fistula to the LV. Okay, all clear on this? So we'll move to the next set, which is name 3 causes of acquired coronary AV fistulae. I just showed you an example of a congenital. But you can sometimes have a patient who didn't have it, but now he's got a coronary AV fistula. So name 3 acquired causes, that's right. One is tetralogy of Fallot. When you do an RVOT PAT, you can actually cut the coronary. And then instead of it entering into myocardium, it's now entering into the heart. Kawasaki, no. Have you ever heard of it? You hear of aneurysms, right? But those aneurysms don't enter into the ventricle. So they are not fistulae. Fistulae per se has to connect one chamber into another chamber. So one is TOF repair. What else? Acquired causes of coronary AV fistulae. Just think of any stenting in adults. Really unusual, right? Because you're stenting the coronary artery which is on top of the myocardium. Think of anything, okay, yeah, septal myomectomy. Think of anything where you're cutting or invading muscle, right? So TOF repair, septal myomectomy. Think of catheters that are used right now, these days by EP guys. Radio frequency ablation, they are ablating. They may ablate through the myocardium into the coronary. Trauma, if you have perforating trauma, you have someone next to you who doesn't like you and puts a sword through your chest, right? So these are the things that you should think of. Septal myomectomy is actually among, because when it's done frequently, but the most common would be TOF repair, muscle bundle resection, because that's the most frequent operation we see. Complication of radiofrequency ablation, penetrating trauma, I shouldn't just say any trauma, and then It can be as a complication of endomyocardial biopsy, permanent pacemaker implantation, and so on. So in any of these, you could possibly get it, but I think your top three should be septal myomectomy, jet repair muscle bundle dissection, and after radiofrequency ablation. Okay, all clear on this? Now, what is the diagnosis here? How would this baby present? What is the important associated anomaly with this diagnosis? So this is a short axis view. This is a spotter. Why do you say it's critical AS? How would you define critical AS? So I agree with you with aortic stenosis, and it is critical probably. So yes, I think the thing to say with this angio would be a unicuspid aortic valve, presumably with aortic stenosis, most commonly presenting as critical AS. Because you'll only be able to diagnose it as critical AS if you also saw your LV and it was dysfunctional, then you could say yes. In this, you're just seeing the valve. Now, can everyone see this? Because this is a spotter. When you look at your short axis and you just see this valve opening like this, from one edge, it's just opening basically like this, like this, like this, like this. This is a unicuspid aortic valve. Okay, so it's basically that all the three commissures get fused. You have just one point of contact to the aortic annulus, and it opens in this way. It can be eccentric, located anywhere at one point of contact. Now, how does this typically present? How does a unicuspid aortic valve typically present? With AS, with AR, or asymptomatic? AS, AR, asymptomatic. Okay, shock from what? So they present from AS. So they present as critical aortic stenosis clearly, and they present as LV dysfunction, so they can have poor cardiac output, can be in shock, but they will present as severe aortic stenosis. What is the most important associated anomaly with a unicuspid aortic valve that you need to look for? And it's not really shown. If you think of shown, you think of supramitral membrane, subaortic membrane, coax, right? Parachute mitral valve. You don't talk about unicuspid aortic valve. That's why the answer is coarctation. So the most important associated anomaly is coarctation. Now, in terms of treatment, what do you do for treatment? Can you balloon these? You can balloon them, but the prognosis is very poor, right? So if you balloon it, you can do a ballooning, but I think when you say balloon aortic valvuloplasty, you must qualify to the patient as well as to your ICU team that look, I'm going to balloon it, but the prognosis is not good. There may be, see, there's all commissural fusion, right? So what are you tearing? You're essentially tearing the valve. So they can have aortic regurgitation. So if they have a LV that is poorly functioning, on that you add an acute volume load of aortic regurgitation, the LV may not tolerate it, and you can go into sudden death on the table. You can go into massive aortic regurgitation. So if you want to do ballooning, you can do it, but with the caveat that it may not work. I may have a complication. There may be severe AR. This patient may need an emergency surgery. Talk to your surgeon. Make sure he's available. And if they need a surgery, a neonatal Ross, aortic valve replacement is not a great option in a small baby. Because if you replace the aortic valve in a small baby, what happens? Say you go and put a valve in this 2-month-old baby, and you put a metallic valve. What's going to happen over time? What is going to be the? So one is you need to put warfarin, that's right. So anticoagulation in a baby, monitoring the INR. Second is redo surgery. Will you have to do? Is there a chance you'll have to do? What are the chances of needing a redo surgery? 10%, 50%, 100%. 100%, right? You put an aortic valve. What is the annulus of this aortic valve? Maybe 6 mm, 8 mm. You put an 8-10 mm aortic valve, you will have to replace it as the baby grows. Now, not saying that Ross you won't have to replace. Typically in Ross, what do you have to replace? So the new fellows, everybody is clear what a Ross is? You take the pulmonary valve, put that in the aortic position, and what do you put in the pulmonary position? You're taking pulmonary valve, putting it in aortic position. What goes into pulmonary position is the homograft, right? So that homograft has to be redone. So even in Ross, everybody talks about Ross as a great alternative. The reason being that you don't need the warfarin. So if you do it in a small baby, at least in their growing years, you don't have to worry that every time they hit their head, they may have an intracranial bleed. So you don't need to worry about the warfarin part, but you certainly will probably need replacement. Your homograft will have to be redone in a Ross. So either way, it's not a great situation, and that's why the prognosis with unicuspid aortic valve is not great. If you have a bicuspid aortic valve with aortic stenosis, you can certainly do balloon aortic valvuloplasty. Your risk is if you overdilate, you may get aortic regurgitation. That's why you underdilate. That's why you use a low pressure, low profile balloon. Last week we discussed balloons for peripheral pulmonic stenosis, and I told you they have to be what kind of balloons? For peripheral pulmonic stenosis, just making sure you are listening last week. So for stenosis in the peripheral arteries, what kind of balloons will you use? High pressure balloons, which are typically high profile because they don't respond well to tie shaft and low pressure. For balloon aortic valvuloplasty, what kind of balloon will you use? Which balloon would you typically use for a balloon aortic valvuloplasty? You typically use tie shaft. Tie shaft is 1 to 2 atmospheres, which is a low pressure balloon. And the reason is because it's valve, they're quite pliable, you're just tearing the commissures and it should work. So if you have bicuspid aortic valve with AS, balloon aortic valvuloplasty with tie shaft balloon, good option. If you have unicuspid, someone shows you this picture, say I will balloon, but it may have AR. This patient is a high-risk candidate. The results are not great. We could do a Ross, but then we still have to replace the homograft. So either way, prognosis is not that good. And you must remember this associated anomaly of coarctation. The reason being, if you don't remember it and you don't look for it, now what's going to happen? How are the femoral pulses going to be when you have a unicuspid? If you have this baby, and Vidhu said it's critical AS, how are the pulses going to be? What will the pulses be? Pulses are going to be low volume, right? Because there's hardly any cardiac output, so the pulses are going to be poor, weak in all the limbs. So when they're weak everywhere, you're not going to be thinking of quart, and there's hardly any output coming for you to think of quart. Therefore, you need to look very closely at the arch. Will you get a gradient across the quart? Do you think you'll have a gradient across the coarctation? Why won't you have a gradient? Why do you say no so confidently? Why won't you have a gradient across the quart? And the answer is right, you may not have a gradient because you've got low cardiac output is one, right? You've got proximal obstruction is two. There's no forward flow. So where you can only get a gradient when there's forward flow. So in the presence of a proximal obstruction, distally you may not get a gradient. In the presence of LV dysfunction, there's poor output, distally you don't get a gradient. So that is why quart can get missed. So what happens? You go in and open up the aortic valve and you're still in shock. So your way to look at it is to look carefully at your arch on 2D. Sometimes we've given like dobutamine to try to increase the output to look, but that's not a good idea because you shouldn't increase the myocardial contractility when there's a fixed obstruction. So basically 2D, looking at the arch, making sure its measurements are okay and that there's no associated quart. Okay? All clear on this? Any questions? We'll move to the next one. What is the diagnosis here? Diagnosis and associated cardiac lesion. Clear Robin. Okay, right. That could be the jaw is very small, right? Okay, I'm showing you like this. The neck. Turner, that's right, right? So you see the webbed neck. So you think of this could be Turner. So what are the associated lesions in Turner syndrome? So you all know the Turners, the features of Turner syndrome, right? Short stature, low hairline, coarct of aorta, of course, is the one. Underdeveloped breast, elbow deformities, no menstruation, so on and so forth. So what are the associated lesions with Turner's? And really the question is, apart from coarct. So we know coarct is the most common associated lesion of Turner. You need to know the other lesions. And it's not VSD, my friends. Everything is not VSD. Okay, bicuspid aortic valve. What else? So coarct is something that you should, of course, right away say when someone asks you for Turner. You say coarctation. But remember this, which is ascending aortic root dilation and dissection. You only think of ascending aortic root all the time in which lesion? Which lesion do you think of ascending aortic root dilation? In Marfan's. Right, when it's ascending aortic, we think of Marfan's. But it can happen in Turner's. And the importance of this is, in Turner syndrome, you have to do an echo, even if they have no coarct, every 5 years, looking for ascending aortic root dilation. Okay, so this is something not to forget. Bicuspid aortic valve, the coarct bicuspid aortic valve, and the fourth is PAPVC. So partial anomalous pulmonary-venous connection can also occur in Turner's. So important to look for that on echo when you have a child with Turner's. So these 4 lesions you must remember, coarct of course, and then remember the ascending aortic root because it changes your follow-up. If your geneticist sends your patient with Turner's, echo is fully normal, they are one of the lucky ones, you still need to tell them, come back every 5 years. I need to look at your ascending aorta and make sure it's not getting disproportionately dilated. So ascending aortic root dilation, apart from Marfan's, one more cause to keep in mind is Turner syndrome. Okay, so I think this is my last one for you guys. Bonus question, name of device, what is the size of the waist, what is the indication for usage? It's an ASD device. Which ASD device? Is it your standard Amplatzer? Okay, so it could be a PFO device. Anyone the name of this device? What is unusual about it if you look at it, right? It's an Amplatzer, yes. It's from the Amplatzer family, but it's got a particular name. If you look at its waist, it's got a very narrow waist, and then it's got very big discs, right? Typically in your Amplatzer ASD devising that you do, what is the size of the waist? Right. So this is a fenestrated ASD device for fenestrated ASD closure. What is the name of this device? Starts with a C. Now available actually in India, so you all should read up on this one. So this is the Cribriform ASD device. Okay, it's called the Cribriform. Cribriform because it can close multiple holes in one shot. So if you look at it, it's got, what does it have here? It's got a very narrow waist. So you're going to put it through the central. Say you've got multiple penetrations, right? You can't put one Amplatzer in to close it. So you put a Cribriform through the center of those holes. The waist is hardly 3 millimeters. Then these discs on both sides, there are 2 sizes, 25 mm, 35 mm. So basically what do? They are just covering up the whole atrial septum. So whatever small holes are there gets covered up within it. Now I asked you, what is the waist size in your regular ASD device? When you do ASD device in the cath lab, what is the size of the waist? Is it 8, 10, 16, 18? It depends on the size, right? So if you're closing a 20 mm device and you're using a 20 mm ASD, it's a 20 mm waist. So the waist size depends on the you're going to use. It can be anywhere from 6 mm till 38 mm, right? But in a Cribriform device, the waist is always 3 mm, goes through the central part of the fenestration, and then its discs are always only 2 sizes, 25 and 35. Because typically in fenestrated ASDs, when you're going to close it, you will at least have 2.5 centimeters of atrial septum. And it just goes, it's like a little, imagine a sandwich with multiple little cucumbers and tomatoes in there. So the 2 pieces of bread just go and close off all the fenestrations in there. So this is a Cribriform ASD device brought out by Amplatzer. I don't think the Chinese have copied it because it's not used that often. And what is it made of? What material? It's made of nitinol. That's right. So it's the same as the arm plaster, looks the same except narrow waist. And which disc size is that the question? Which disc size you use depends on. So it depends on two things. One is it depends on the total atrial septum. Like let us say your atrial septum measures 27 millimeters. Obviously, you can't use a 35 device. It's not going. There's not enough space. So then you have to use the 25. If your atrial septum measures 40 millimeters, then you can use either 25 or 35, right? Then it depends on the fenestration. So you take all the fenestration from the most further away fenestration on this side to the most further fenestration on that side. You measure that distance. If that distance is say less than 25, then you can use a 25 device. If they are separated by 30 millimeters between the two here, then you need a 35 device. So that's how you will decide on the device size. Depending the same way you do with your atrial ASD device. If you have a two defects, they should be, the second defect should be within how many millimeters of the first, the end of the second defect, for it to get covered by one device. Not 3, 5, 3, 7 right? Because this is your waist and this is 7 this is 7 So the second defect lies within 7 from the first defect, and if its edge is within 7 then one device will cover both those. So it's the same method, same principle that you use for this. Yeah, typically you can just say 7 as your answer, though some of the larger devices, ASD devices, it's up to 8 6 I don't think, but 7 you can just, 7 is pretty standard. And that's the same mechanism for deciding on how to choose your cribriform. Is that clear to everyone, how you choose the size depending upon the distance of the ASD? Okay, so I think it's 8:45. We'll end with that. Next Thursday at 8 o'clock will be Dr. Parvati Iyer on post-op pathology management. And then we'll, I think I'll step into the schedule for the rest of the month after that. Any questions?